I do want to start off by just talking through the article that you read to get a little bit more of the background, the methods, the results. And then we'll talk about just general biases in research, and we'll come back to this article to think about what were the limitations in this article, or what were the biases that they observed in this study. But we will start with just reviewing the article for today. So a lot of what Frederick said is here. The background attention has been primarily around disease-specific care. So we know a lot about HIV care, and we know a lot about tuberculosis care, and we know a lot about malaria care, but there's not as much information about general primary care. So the most common illnesses that adults and adolescents present with. And there's no benchmarks for quality of care in outpatient departments. So there's nothing that we can really point to say, oh, that outpatient department's doing really, really well. We don't have any way that we're currently measuring to say that things are doing well or doing poor. So then what were the objectives of this study? What were they trying to achieve in this particular study? The goal for this study was to describe the quality of care. And then, Neza, you're right. They're hoping by looking at where there's successes and where there's gaps, they can make some suggestions for improvement and propose interventions that can address these gaps. So the study setting, it took place in Southern Kayonza District at all 8 health centers that are Ministry of Health run and supported by Partners in Health. It was a cross-sectional study, and again, we'll talk more about cross-sectional studies in the future, but that's when you take a snapshot. So it wasn't that they found a patient and they followed that patient for a long time. They looked at one point in time to see what was the care that patient received on that day. So they're taking a picture of the clinic for that day. That's what we mean by cross-sectional. It is a snapshot, one point in time. Any individual who was 13 years or older was eligible for the study. And all individuals who presented to the clinic on the day of the mentor visit were invited to participate. So the mentor went to Cabarondo Health Center, and when an adult came in for primary care, he asked the adult, do you mind if I observe your visit for today? I just want to assess some quality of the visit. And the patient, if they said no, then the mentor would leave the room. If the patient said, yes, it's okay, you can observe, then the mentor would sit there and assess would go through the checklist. Did they ask for temperature? Yes. Did they ask for weight? Yes. Based on what they observed. So intervention description. There's actually no intervention in the study. They're just observing what is happening in the general outpatient clinics in Southern Kayonza. The data was collected by the mentor. So the mentor went to the site and was trying to get a baseline of what was happening in the clinics, and they just sat in the room and did the checklist as they went through. They took direct observation. So as Jean-Pierre is giving care, they actually said, did he ask for temperature? And they're observing. That's how they're getting the information for the study. And then the mentor, at the end of the study, also recorded their diagnosis and treatment. So they recorded the diagnosis and treatment of the nurse, of whatever the nurse said is wrong with the patient and what the nurse prescribed. And then the mentor said, in my opinion, I think the diagnosis should have been this and the treatment should have been this. So that was all recorded in the data collection. There were 2 primary outcomes. One primary outcome was whether or not the nurse gave a correct diagnosis. And a second outcome is whether or not the nurse gave a correct treatment. How did they define this? What is a correct diagnosis? How did they decide if the nurse's diagnosis was the correct diagnosis? So the correct diagnosis was the agreement of the nurse with the clinical mentor in terms of diagnosis or the same in terms of treatment. Okay? So they're really treating the mentor as what we call the gold standard. So whatever the mentor says is true, and we say that the nurse is correct if he agreed with what the mentor said. If the mentor said that the diagnosis should have been pneumonia, if the nurse said pneumonia, we said it was correct, and if the nurse said something else, then we said it was incorrect. And you should start thinking now, when I ask you later about problems with research, you should start thinking about whether or not you think that is a good way to define correct diagnosis, or if there's maybe some problems with defining it that way. And then in terms of analysis, they reported frequency, so the percent of correct diagnoses that were correct, the percent of treatments that were correct, with 95% confidence intervals for outcomes. And last week we talked about confidence intervals, and we're going to revisit them today. Their ethics statement is that it was routine program monitoring, so there was no informed consent, but they could opt out. So the mentorship program and the mentorship observations are part of our clinical care for the mentor program. And so we didn't specifically get consent. We're just reanalyzing the mentor's data for this research. But when the mentor is there, they do ask the patient, are you okay for me to be here to observe your visit? And if the patient says, no, we don't want someone else in the room, then they leave the room. So it is a routine program activity to have a mentor in the room, and we're using their program data for this analysis. But the patient could say, no, I want to be alone with a clinician, or I want to be alone with a nurse. And the study received ethics approval from RNEC, that's the Rwanda National Ethics Committee, from Partners Healthcare, so that covers anyone who's from the Brigham and Women's Hospital who's doing research, and London School of Hygiene and Tropical Medicine, IRB. So Ashwin, who's the first author, is based at that school, so he also got permission from his school. So the results, the quality indicators, if you look at Table 3, this is describing some of the key assessment areas that they felt like they should have assessed and whether or not they happened. So based on these assessment areas, what was most likely to be assessed in the clinical encounter? So based on Table 3, which of the key activities was most likely to be assessed? The weight of patients was the most likely to be assessed. What proportion of visits did the patient have their weight assessed? And what proportion of visits, Nadine? 62.6%. So then I'm going to ask you, do you think that is good quality or bad quality? What percent do you think they should be having their weight assessed? 100%, right? And we're now at 62% getting weight assessed. So it is a growth opportunity for us, right? We can encourage the nurses to be taking weight more often. What areas were not assessed at all based on the data from the mentors? Height was not assessed. BMI was not assessed. Respiratory rate, and then, yeah, the table goes on, pulse. So there's a lot of areas that are not being assessed at all. BMI, I would think, would be a very important area to assess, right? BMI is an indication of malnutrition. BMI is an indication of obesity, of other NCDs and chronic diseases. BMI is an indication of disease. Oftentimes when someone has a very low BMI, they have some other disease that's causing them to have low BMI. But according to the data collected by the MESH mentors, in 470 observations, no one had BMI measured. It is a real growth opportunity, right? Where we can improve our programs to get BMI measured. Now here is Table 4, and I asked you in your discussion questions or the questions before class to think about Table 4 a little bit more. So this is looking at two things. It's looking at the percentage of encounters that had correct diagnosis, and it's asking about the percentage of encounters that had correct treatment. And they have it by different categories. So this is overall. This is if they had back or joints pain. This is if they had coughing or difficulty breathing, and so on. And I said, suppose that they had set 80% as their target. So our target is to have 80% of nurses giving correct diagnosis. And our target is to have 80% of nurses giving correct treatment. So my question is to you, based on this target, and looking at your estimates and your confidence intervals, what can you say about the correct diagnosis and the correct treatment compared to this 80%? Okay, so if 80% was their target, looking at their estimates and their confidence intervals, what can you say about these nurses in terms of correct diagnosis and correct treatment? If you're looking at it with pictures, you say, what is my target? In this case, 80%, okay, is my target. And I'm going to be comparing the confidence intervals and where the confidence intervals lie in relation to this target to be able to say something about significance. So let's look at that first, the total agreement. Who can tell me what is the 95% confidence interval for correct diagnosis in the total agreement? What is the lower number for the 95% confidence interval? What is it? 45.7? And what was the top number of the confidence interval for total correct diagnosis in the total agreement? 54.8%. Okay. So remember the confidence interval. When I do a study and I take a sample, so in this case we observed about 400 people. I don't know the truth. I did not look at every patient who came to Southern Kayonza. I looked at 400 patients that came to Southern Kayonza. So I don't know the absolute truth. I have some uncertainty, and that uncertainty is reflected in my confidence interval. So I don't know the truth, but I think that this interval covers the truth. Am I 100% sure it covers the truth? No. What percent sure am I? I am 95% confident that this interval covers the truth. So I look at what I think is the truth. I think this covers the truth. And I look at my target. And what can I say when I compare this interval to my target? It's significantly different. I don't know the truth, but what I can tell you is the interval that I think covers the truth is very far away from what my target is. And so I say it's significantly different, or you might even go on to say it is significantly below what my target is. Using that, let's just look through the list. Which of these can we say are significantly below? So let's look at correct diagnosis. Total agreement, is it significantly different from 80% or no? Yeah, so it's significantly what? Above or below? Below. I'm just going to put SB for significantly below. Joint and back pain, where does it sit? Above or below? Significantly below. Cough and difficulty breathing, significantly below. Diarrhea, no evidence. Epigastric pain, significantly above, right? This is a case where they actually had better diagnosis than our target. Fever, significantly below. So let's look at the symptoms for females and males. So for females, significantly below. For males, significantly below. Headache, significantly below. Mouth and throat problems, no evidence. Perfect. In skin problems or lumps? No evidence of a difference. Okay. And I'm not going to go through the list of treatments, but the same logic applies, okay? If you want to compare it to some target, then we use this logic of comparing it to the target using the confidence interval. So we're now researchers. We don't just look at the estimate, we have to look at the whole interval to be able to make conclusions about the program, okay? Now I'm going to turn Nadine's question or comment back before. If I had said that 80% was my target for good quality, what would you say about the quality based on where these confidence intervals fall? So I want 80% correct diagnosis. Did I achieve that with overall? Did I achieve it in back or joint pain? No. So for the most part, I'm not achieving, if 80% was my target. Now I will say, I just made up 80%, okay? I made up 80%. Maybe you think 70% is okay, or maybe you think 90% is necessary. But that's how you would use that to interpret where you are with some targets. So based on this, the authors conclude that low quality of care, and it varies by health center, so some health centers are doing better than others, that there's a need for better nurse training, that they need to develop protocols like the IMCI protocols for adults to help standardize care across health centers, and that protocols should be complemented with sustained mentorship. So we can't just say, go off and do this protocol. We need to be training and we need to be giving mentorship and supervision to improve the quality of care being offered. Do you think those are reasonable conclusions? And my question to you is, do you believe the results? So I present this very fancy study to you. It looks nice. It's in a published paper. Do you believe what they've presented to you? Do you believe that quality of care is what they reported? Do you believe the challenges that they describe are really what is happening in Southern Cayuga?